My topic for presentation today is Wilms tumor. Now, why learn about this topic? Because Wilms tumor is the most common malignant tumors of kidney in children, ranging up to 91% of the tumors arising from kidney. Also, it forms 6% of all pediatric tumors. And as far as the history is concerned, Karl Marx Wilms, the German pathologist and surgeon, both as one person, he described Wilms tumor in 1897 and 1899 in his two seminal papers and gave us a picture into the mixed origin of Wilms tumors. Now we can see over as the history progressed in 1899, when Wilms described this tumor first, the 5-year survival rate was only 5%. It has progressed now to 92% or more than around 95% by around 2003-2009. Now it is the first solid malignancy where the value of adjuvant chemotherapy was established. It was because of the establishment of adjuvant chemotherapy, the survival rate has improved drastically over the period of years. And two groups, the Children Oncology Group, which was formerly called National Wilms Tumor Group, and Society International de Oncologie Pediatric, the SEOP group. From now on, we will call the first group as COG and the next group as SEOP. These are the two groups which pioneered the chemoradiation in Wilms tumor and brought about these good results in Wilms tumor. Both these groups have good results on the management of Wilms tumor, but their philosophy differs. Coming to the epidemiology, it is the second most common malignant abdominal tumor in childhood after neuroblastoma. The mean age of diagnosis is around 3 years. It is rare in more than 10 years of age and less than 6 months of age. Bilateral Wilms tumors occur in 4% to 13% of patients, and congenital syndromes are associated with 10% of tumors. Coming to the molecular biology, when Wilms tumor was identified, aniridia, genital abnormalities and mental retardation were seen associated with it. So this was one of the first congenital syndrome with which Wilms tumor was identified. On looking for the genomic problems, they found that there was a deletion at 11p13 in chromosome 11. So it was termed the WT1 gene. And it acts as a function of this gene is as a tumor suppressor, and that is why the deletion of at this foci causes Wilms tumor, the Wager syndrome, Wilms tumor, aniridia, genital anomalies and mental retardation. It was also associated with another syndrome, WT1 gene, which was later found. It is called the Denistras Syndrome, which is associated with male pseudohermaphroditism, progressive glomerulonephritis, diffuse meningeal sclerosis and Wilms tumor. And another clinical association with Wilms tumor was found with microcephaly, earlobe crease, macroglossia, umbilical hernia or omphalos and hemihypertrophy along with the Wilms tumor. So this was called Beckwith-Wiedemann syndrome. Now when looked into the chromosome, it was found that the problem was at the 11p15 locus and it was termed the WT2 gene. So WT1 gene and WT2 gene both in chromosome 11 is associated with Wilms tumor. Other chromosomes which are associated are 1p and 16q. Loss of heterozygosity in 1p and 16q was associated with Wilms tumor. This is from the blue is from the mother and the red is from the father. So a typical gene should be heterozygous in a child, should be heterozygous, one from the mother and one from the father. But what happens is that when there is a disruption in the genetic sequence from mother or father, what happens is the adjacent chromosome try to repair it. And when this repair happens and then the duplication happens during the meiosis period, what happens is we can see the heterozygosity is lost here. We can see the heterozygosity lost in both these groups. When a different type of repair happens, we can see the loss of heterozygosity in one of these loci. So, when the loss of heterozygosity occurs in 1p or 16q, the chance for Wilms tumor increases. We can also see that when loss of heterozygosity occurs in 1p only, the relapse rate is lower. When it occurs in 16q, the relapse rate is more in case of Wilms tumor. When loss of heterozygosity occurs in both the loci of 1p and 16q, the recurrence chance of Wilms tumor is more. Now, others associated are, one is beta-catenins. Beta-catenins are associated with the WNT pathway, which is a pathway associated with Wilms tumor. And it was also found that Wilms tumor showed an X-linked inheritance in some cases. So, that syndrome includes this macroglossia and polydactyly and male pseudohermaphroditism. This is associated with WTX gene. So, Wilms tumor can also show an X-linked inheritance. TP53 is associated with generally a worse prognosis in Wilms tumor. So, the syndromes and tumor risk. The syndromes associated with Wilms tumor are Weger syndrome, Denistras syndrome, Beckwith-Wiedemann, Simpson-Golabi-Behmel. All these syndromes are associated with Wilms tumor. We can see the tumor risk here. So, the highest rate is, we can see this is with Denistras syndrome. 90% of the people with Denistras syndrome will have Wilms tumor, and it is 30% in Weger syndrome, and lesser with Beckwith-Wiedemann, Simpson-Golabi-Behmel, which is syndrome associated with organomegaly, renal dysplasia, polydactyly, and heart defects. There is another syndrome called Frazier syndrome, where it is associated with WT1 gene. The problem with WT1 locus, but the tumor risk of Wilms tumor is rare. Now, clinical presentation of Wilms tumor can be with asymptomatic, can be an associated asymptomatic abdominal mass, or during evaluation of abdominal pain it is incidentally detected, or gross hematuria has been reported in 18.2% of the patient, and microscopic hematuria in 24.4% of the Wilms tumor. When the pelvis is being involved by, renal pelvis is being involved by Wilms tumor, hematuria occurs. 10% of the Wilms tumor children will have coagulopathy. There is an acquired von Willebrand disease associated with Wilms tumor, which is the exact cause is not known, but so Wilms tumor can present with coagulopathy, and there is a chance for perioperative bleeding in those cases. It can also 20 to 25% can present with hypertension, fever, anorexia, and weight loss occurs in 10% of the patients, and extension of the tumor thrombus into the renal vein. This can obstruct the spermatic vein and result in a left varicocele. Extension into the atrium of this thrombus, tumor thrombus, can produce cardiac malfunction. And tumor rupture and hemorrhage, the patient can present with acute abdomen. So the differential diagnosis can be hydronephrosis, a neuroblastoma, hepatoblastoma, rhabdomyosarcoma, and lymphoma. All these are differential diagnoses of Wilms tumor. Now, how to differentiate Wilms tumor from other diagnoses? For that, we have to go for investigations. We can do a routine investigation, typically routine investigation, and urinary VMA can be performed to rule out neuroblastoma. Spot VMA or 24-hour VMA can be positive in case of neuroblastoma, or it will be negative in Wilms. RFT has to be looked for, and further imaging studies will help to differentiate between other tumors. On imaging, abdominal X-ray and chest X-ray has to be taken. Abdominal X-ray in Wilms tumor can show the tumor is here. We can see a displacement of the loops to the right side. Chest X-ray, we have to look for any metastasis. Ultrasonography. Ultrasonography will help to differentiate the lesion from hydronephrosis and to localize the mass to kidney. We can go for a Doppler and see whether the tumor thrombus is extending into the renal vein or the IVC. CT scan. In CT scan, we can see the extent of the mass, and during the CT urogram phase, we can assess the renal function. Opposite kidney has to be assessed both for function and for any tumor lesions or a nephrogenic risk in case of Wilms tumor. Here we can see the tumor in the left kidney, and we can see the opposite kidney is relatively free, and we can see a hepatic metastasis here. Tumor thrombus invading the portal vein can also be visualized in this lesion, in this CT scan. Now MRI, is there any use for MRI? MRI does not generally give any additional information when compared to CT. But MRI has its own advantage. It helps to differentiate between the nephrogenic rust and Wilms tumor in kidney when it arises, especially in bilateral Wilms tumor. Now, we have already said about the Child Oncology Group and Society International Pediatrics, CEO, and we have already said that their philosophies differ. How do their philosophies differ? In the COG group, Child Oncology Group, they would primarily approach the lesion by surgery and then go for a post-operative chemoradiation. Post-operative chemotherapy and radiotherapy is required. Whereas in SIO, the yellow SIO group will go for a preoperative chemotherapy initially, reduce the size of the tumor, then go for surgery. And while doing preoperative chemotherapy, the tissue diagnosis is not frequently needed, and then go for surgery, and finally they go for a post-operative chemotherapy. So does this make a difference, big difference? Yes, it does make a difference, because in this group they get a fresh tissue for the pathological staging. They take the tumor as such. Whereas in the SIO group, they get a burnt tissue after chemotherapy. After the preoperative chemotherapy, the size may be reduced and some amount of the tissue may be decreased, and there can be regressive changes in the tumor. And so for pathological staging, they get this burnt tumor tissue. So further treatment will depend upon the pathological staging. So due to the difference in approaches, the post-operative chemotherapy in both the SIO group and CO group will differ very much, and their surgical approach will also differ. We'll see how. So we can see the staging of the tumor. The staging of the tumor is similar in SIO stage and the CO staging, or the NWTS staging. We can see in the stage 1, the tumor is basically in the kidney. It is seen in the kidney. In stage 2, the tumor has been extended outside, but it can be resected completely. Only maybe a microscopic residual tumor, maybe there are no macroscopic residuals are visualized. In stage 3, there can be lymph node involvement, local lymph node involvement, and the preoperative rupture preoperative rupture or diffuse spillage can be seen, and invasion beyond the capsule, and the tumor may not be completely excised, or there can be a macroscopic residuals of the tumor. Whereas in stage 4 lesions, there is hematogenous metastasis, pulmonary or liver metastasis, and lymphadenopathy beyond the abdomen and pelvis. And stage 5 is bilateral Wilms tumor, both in SIO and CO staging. So does that mean that the staging is similar? No, the staging is not similar, because the timing of surgical resection is different in both these cases. And histopathological staging is also different, because there can be chemotherapy-induced changes and downstaging in case of SIO tumors. So coming to the pathology of Wilms tumor, especially when the fresh specimen is received, what is seen in the pathology? So the problem with the pathologist is that we can see a numerous differential diagnoses for pathologists as far as the Wilms tumor concerned, ranging from renal carcinoid, malignant abdominal tumor, lymphoma, mesenchyma, renal teratoma, neurogenic tumors, congenital mesoblast nephropathy, renal adenocarcinoma. Why this lot of differential diagnosis for Wilms tumor? This is because we can see these are the initial, this can see the development of the glomerulus. This is the initial blastomal cells, this dark blue cells, and finally we can see both the tubular structures, which are the epithelial structures, and the stromal elements, the stromal element in the case of a matured glomeruli. So all this is changing from the blastomal cells to progression into the stromal and the tubular, stromal and epithelial structures happens in the kidney in development. So what is the Wilms tumorigenesis? We'll just brush through it and then go in for detail. So initially there is a blastema cell which can persist and cause a nephrogenic rust. This nephrogenic rust can either become dormant and regress and go off like that, or it can become hyperplastic, or it can cause there can be a neoplastic change to it, or an neoplastic change to which will be localized there and producing an adenomatous benign lesion, or the neoplastic change can break off the membranes and there can be anaplasia and finally turns into a Wilms tumor. When we say just like that, it is not completely understandable. So we'll go into detail. So this is the initial blastemal cells, and this is the final differentiated form of the glomerulus with stromal and epithelial elements. So this is the stromal cells. From the blastema there can be a stromal cell. Strong is mental. There can be a stromal development, and there can also be an epithelial development like that. So initially there is only blastemal cells. The blastemal cells can develop into a stromal and epithelial elements in the adult kidney. So what is nephrogenic rust? We can see the adult kidney, there should be only both the stromal and epithelial cells properly arranged. When the blastemal cells are persisting like that, it is called a nephrogenic rust. What can happen to the blastemal cells? It can either regress, no problem, regress, and it can become obsolete. Or what happens is the blastemal cells can be hyperplastic, it grows in the number. And once it happens, this blastemal cells can go in for a neoplastic change. If the neoplastic change is only at that point, it can be an adenomatous nephrogenic rust. But if it is progresses and there can be associated anaplasia, it becomes a Wilms tumor. So does that mean that Wilms tumor only contains blastemal cells? No. It means that Wilms tumor is like a family. We have the tubular epithelial, the stromal epithelial, the stromal cell at different stages of development, and we have the blastemal cells. So it will have the cells of, it is a triphasic, it will have cells of blastemal origin, it will have cells of strongman stromal origin, and we have the cells of epithelial, female epithelial origin. So blastemal, stromal, epithelial. And in these cells there can be anaplasia. So there is neoplastic cells, this anaplasia can also be seen, and that amount of anaplasia is an important factor in the prognosis of Wilms tumor. So what is anaplasia? To term something as anaplasia, there should be an enlargement of nuclei. How much enlargement? 3 times of enlargement. Of which type of cell? Of both epithelial, stromal and blastemal cells. We can see an enlargement of the nuclei. We can see also there is an obvious hyperchromatism, a dark nuclei, and there is also multipolar mitotic figures. The multipolar mitotic figures are also seen in anaplasia. If these three factors are seen, it is anaplastic. So this is a typical triphasic pathology seen in Wilms tumor, where we can see the blastemal blue small cells, and we can see the stromal elements, the skeletal muscle, the pinkish color, the stromal elements, and we can see the epithelial cells, which are the tubular like structures. So there is blastemal, stromal and epithelial elements. It is called the triphasic pattern. Next pattern is we can see a biphasic pattern, where we can see a blastemal element here and we can see a stromal element here. This is the biphasic pattern. Wilms tumor can occur as also monophasic. Here we can only see the blastemal pattern. So when we initially discussed that we have seen a lot of differential diagnosis of Wilms tumor. This is because we can see in this Wilms tumor, the stromal group has gone in for a skeletal maturation. It can go beyond the normal maturation into the skeletal maturation. And this is a completely undifferentiated blastemal cells. So when there is skeletal muscle inside the tumor, always a suspicion of teratoma happens. When there is a neural differentiation, suspicion of neuroblastoma happens. When there is different epithelial differentiation or a different stromal differentiation, all the sarcoma, a rhabdoid tumor, all this differential diagnosis can happen in Wilms tumor, especially when it is monophasic or where the sampled area is monophasic. So that is the reason for diagnostic confusion in Wilms tumor. But once 3 cell lines are seen, the diagnosis of Wilms tumor is quite confirmatory. So this was the pathology what the Koch people could approach. They got the virgin specimen where no chemo radiation is given. Preoperative chemotherapy is given. Now pathology of PSYOP people was different. They were not much bothered about initial tissue biopsy for Wilms tumor. So if anaplasia was the basis of histology for classification of Koch staging, but as far as the PSYOP classification, it is the cell differentiation and the chemotherapy induced regressive changes. So based upon these changes, they have differentiated into low risk, intermediate risk and high risk group. The low risk group is a completely necrotic nephroblastoma or cystic partially differentiated nephroblastoma. Intermediate risk is the regressive epithelial stromal mixed or focal anaplastic nephroblastoma. And high risk, there is a blastomal or a diffuse anaplastic nephroblastoma. So blastomal element and diffuse anaplasia is associated with the high risk, whereas focal anaplasia is with intermediate risk, whereas a necrotic nephroblastoma is a low risk. After chemotherapy, everything has gone in for necrosis. It is a good prognosis. So now treatment approach. We have said that the treatment will differ in PSYOP and Koch. So this is the treatment approach of Koch. Initially surgery and then for the post-operative radiation. The post-operative radiation will depend upon whether it is a favorable histology or unfavorable histology. Favorable histology where there is no anaplasia and unfavorable histology when there is a high amount of anaplasia. So in stage 1 and stage 2 lesions, in stage 1 lesions it is dactinomycin and vincristine and in 18 weeks, and stage 2 lesion with favorable histology it is 18 weeks of dactinomycin and vincristine, and stage 3 and 4 with favorable histology is 24 weeks of dactinomycin, vincristine, doxorubicin is added but it has a long-term cardiac problems. Radiotherapy of tumor bed of the involved site is given, but radiotherapy of the tumor bed has its own problem with the local increased risk of malignancy to other organs. In stage 2 to 4 unfavorable histology, this dactinomycin, vincristine, doxorubicin along with that cyclophosphamide and etoposide is also added. Now coming to the COP staging, COP treatment. COP treatment, they have the initial preoperative chemotherapy. So preoperative chemotherapy will depend upon the clinical staging. Many a times the pathology is not required. Depending upon it, it will be divided into a localized tumor or a metastatic tumor. If it is a localized tumor, 4 weeks of dactinomycin and vincristine is given followed by surgery. If it is a metastatic tumor, 6 weeks of dactinomycin, vincristine and epirubicin is added and then go for the surgery. So after preoperative chemotherapy, surgery is performed and then comes the postoperative chemotherapy. The postoperative chemotherapy regimen is like this, will depend upon the stage and will depend upon the risk group. So we have already said the low, intermediate and high risk groups. So depending upon whether it is a low grade, intermediate grade, the treatment with dactinomycin, vincristine, epirubicin is added. In this when it is more stage increases, epirubicin is added, and when there is a local, to prevent the local recurrence, radiotherapy of the tumor bed is given. So that is the approach, treatment approach of COP. Preoperative chemotherapy, then going for surgery and then for the postoperative chemotherapy regimen. What about surgery now? Surgery is similar in both. There is some difference. The transverse upper abdominal incision is given. The peritoneal inspection is done to look for in the liver, in the omentum, in the mesentery to look for any metastasis of the lesion. And opposite kidney was has opened and both sides are seen to see whether there is a transperitoneal approach is performed. This is a transperitoneal approach, and the opposite kidney is visualized and see whether there is any tumor. But nowadays it is becoming less and less popular, because due to the high resolution CT scans, we can see whether there is any nephrogenic rest in opposite kidney or whether there is any tumor in the opposite kidney, and many times exploration is opposite kidney is not warranted. After that, we can reflect the colon of the ipsilateral problematic kidney, and we can identify the vasculature and the ureter and the gonadal vessels, and we have to keep our dissection outside the gerotas fascia. Then we have to ligate the artery first and then the vein. If we ligate the artery first, the kidney will reduce in size and it will be easier to remove. And then the posterior dissection and the superior dissection is carried out. On the left side, when we go for the superior dissection, we have to be wary about the pancreas, the tail of pancreas. And finally, the tumor is removed en masse by sweeping some amount of lymph nodes along with the vessels, and ureter is also tied off, we can see. There are pros for both PSYOP and COG staging. So why COG staging and not PSYOP? Why are they saying like that? Initial surgery and then go for chemotherapy. Because administration of chemotherapy to a patient with benign disease occurs in PSYOP trials. Because many a times in PSYOP trials, they are not going for a preoperative sampling or preoperative biopsy. So, chemotherapy unnecessarily may be given in the case of a benign disease. Also, administration of chemotherapy to a different histological type of malignant tumor can be given. When it is a clear cell sarcoma or a rhabdoid tumor, chemotherapy will be given preoperatively. And modification of tumor histology happens in case of COG staging, and the loss of staging information, because the staging is not done in a virgin tissue, it is done after the chemotherapy. All these are the problems that you should not go for PSYOP, you should go for COG. That is why COG people are saying like this. But COG has its own problems. Because the tumor is virgin, it is friable and there is increased vascularity, and there is a chance of tumor rupture peroperatively, which increases the tumor into stage 3. So tumor stimulation intraoperatively increases the risk of local abdominal relapse and subsequent poor outcome. Also, there can be a failure because of the larger size of the tumor and difficulty in dissection. There can be a failure to sample lymph nodes, which can lead to downstaging and undertreatment of the patient in case of a COG staging. Now, what is the pros of PSYOP? They say because when given the preoperative chemotherapy is given, it reduces the kidney size, and which makes the surgery simpler and reduces the chance of tumor rupture intraoperatively. Also, there is renal sparing. We can try when the tumor is reduced in size, we can look for a renal sparing surgery. Especially it is important in bilateral Wilms tumor or when there is a high risk for opposite side tumor. The answer is the COG says that because the chemotherapy is given, there can be a loss of pathological risk stratification. There can be a problem. But PSYOP has come up with a new pathological risk staging depending upon the chemotherapy, post-chemotherapy pathological specimen into low risk, intermediate risk, high risk, which we have already discussed. And the overall burden of the tumor is reduced as far as the PSYOP is concerned. And with the preoperative chemotherapy, downstaging of the tumor can occur. And they say that the only reduced chemoradiation post-operatively is required because of the downstaging of tumor when compared to the COG staging. So these are the advantages of the PSYOP staging and answers to the question posed by the COG group. But always there is a chance for benign disease to get radiotherapy, chemotherapy. Now, special circumstances is bilateral Wilms tumor and less than 6 months of age tumor. Bilateral Wilms tumor, even the COG group go in for a preoperative chemotherapy because it can reduce the size of the tumor. They are still under study for bilateral Wilms tumor for preoperative chemotherapy. Generally, it is better to give a preoperative chemotherapy in bilateral Wilms tumor, and then reduce the size and then go for a renal sparing surgery. This bilateral Wilms tumor can occur in a synchronous fashion. Opposite side kidney it can occur together, or it can occur in a metachronous fashion which can occur later. So if there is a high risk for bilateral Wilms tumor, it is better to go for a preoperative chemotherapy and decrease the size of the tumor and try for a renal sparing surgery. In less than 6 months of age, even though Wilms tumor is rare in this group, but the problem is they are less amenable for chemotherapy, and chemotherapy has its own problems in the growth phase. So in these patients, because of the lesser tolerance of chemotherapy, surgery is a better option, and generally this less than 6 months have a favorable histology for Wilms tumor. And the prognostic factors of the Wilms tumor include tumor stage, histology, the degree of anaplasia, and the patient's age. If less than 2 years of age, the patient has a favorable prognosis. And biological factors include loss of heterozygosity at 1p and 16q locus and p53. P53 is there, it is a bad prognosis. Loss of heterozygosity at 1p and 16q are also bad prognosis. Then tumor spillage during surgery, all these are bad prognostic factors. So in brief, we have discussed about the introduction, molecular biology, clinical presentation, the diagnosis of Wilms tumor, pathology, the difference in philosophy in the COG and SIOP, how it affects the pathology, pathological assessment, the surgical staging, and the surgery per se, and the postoperative treatment, the surgical treatment, and the chemotherapy pre and post-op, and the prognostic factors. Thank you.